Well, good evening, everyone. I'm Jonathan Meddings, Thorne Harbour Health's Senior Policy Analyst. I'd like to open this event by acknowledging the traditional owners of the lands on which we meet and pay my respect to elders past and present. Sovereignty has never been ceded. The format tonight is a panel discussion and Q&A. Please use the Q&A feature at the bottom of your screen to ask questions throughout the event. Now it's my pleasure to introduce our moderator for this evening, Chad Hughes. Chad is a public health practitioner and implementation science researcher with experience designing, delivering, and studying interventions that address HIV among key populations in resource-poor settings. He is the head of international development and regional director for the Mekong at the Burnett Institute, where he is also the co-head for HIV elimination and oversees a portfolio of projects addressing HIV that embed implementation research to assess effective models of service delivery. We're fortunate to have Chad as our moderator this evening, along with a fantastic panel lineup. So without further ado, over to you, Chad.
Thanks, Jonathan, and good evening, everyone. For those of you in Victoria, some good news about opening up a little bit more in the next few days, so something positive for us all. But welcome on a otherwise fairly cold and rainy day where I am, and probably where you are all as well. And thank you to Thorne Harbour Health for inviting me to moderate this series of seminars and discussions and panels on HIV research and how do we work between researchers and community members. So this is the first of a number of panel discussions that will be run over the ensuing months. And each one will have a different lineup of speakers with different experience. So quite an exciting path forward, and particularly tonight with the panel that we have before us. Whenever I'm asked about the questions of how do we get researchers to work more with community or community to work more with HIV researchers, I find it an interesting question because it frames it in the kind of binary framework where you've got researchers over here and HIV community here, and how do we get these two things to work together? And as somebody who sees themselves very much part of both the research community and the HIV community, I don't fit in that same binary model. I see myself as a researcher and a community member. And I think that's where we want to get to through these panel discussions, is to stop looking at this as a binary where we've got the researchers and we've got the community, and we need to find these pathways for them to engage and work together. Because if you look at all of our panelists tonight and over the coming series, I see them all as both, not one or the other. So somebody who, I guess by profession is a researcher who spends their life and every day working with and talking to and supporting clinically and otherwise people living with HIV, who then becomes friends with those people and collaborators, is very much part of the community as much as the people living with HIV. And the people living with HIV who involve themselves and give over their time and energy and thoughts and bodies to research, and then become integrated into that research process from the beginning to the end, very much become researchers. So I think that's where we want to get to, from my perspective, with these discussions, is not a discussion around how do we get researchers and community to talk to each other and work together, but we get to a point where we just see it as a sort of fluid dynamic where researchers are community and community are researchers. That's my 2 cents worth to start with. You didn't come here to listen to me, and we do have a really exciting panel of experts tonight. What I'll do is I'll introduce each person before I ask them the first question, and then you'll get to know who our panelists are as we move through the evening as well. So our topic is community participation in HIV research. And our first question tonight is going to go to Richard Keane. Richard Keane is the CEO of Living Positive Victoria. He has been engaged in the Victorian HIV response across a variety of roles for over 30 years. He was diagnosed with HIV in 1989 at 19 years of age, and has been a participant in and grateful recipient of HIV-related research. He was first employed in a pilot project as AIDS and injecting drug use educator at Victoria's first needle and syringe exchange program, at the Prostitutes Collective of Victoria in 1990 and was the youngest member of the Victorian AIDS Ministerial Advisory Committee from 1992 to 1996. 3 decades later, he continues to champion and acknowledge the primary role of keeping people living with HIV within biomedical and social research, both historically and into the future, and he's also a wonderful person. Richard, how important is it to involve and consider people living with HIV in HIV research design?
I think it's important, Chad, because it's proven to have worked. And, you know, we're coming up and everyone's at the 40th anniversary of HIV/AIDS, and I deliberately put a couple of things in my bio tonight because I thought they were really important to mention. That I have the privilege of still being here because of the scientific research and the participation that have been developed across that 40 years of HIV response. And I'll talk about it in 2 parts because I think the historical part is really important to get us taking a talk about where we are today. And I think as early years, I was diagnosed in 1989, I was 19 years of age, and I was stepping into antiretroviral treatments and other things. Like it was a really cohesive community and a thirst for knowledge because it really was life or death situation. And all of my peers, particularly the older people that took me under their wing, they were obsessed with it. They wanted to know everything about what was happening in their bodies. They wanted to work with GPs before effective treatments, work on therapeutic solutions for some of the AIDS-related conditions and other things like that. So there was this energy. I think there was a shared vision, a shared commitment as well, given the circumstances that we were facing at that time. And I remember going into some treatment trials myself in those early days and engaging with Ange and the Alfred.
Sorry, Richard, you're just
a trial of blood.
And you can't hear you. You're breaking up. I don't know whether it's an audio issue or a connection issue.
It might be a connection issue. Can you hear me?
Yeah, now we can. It was just before it was breaking up.
Just continue, Richard.
Yeah, no. Sorry, there's obviously a bit of a connection issue going on this evening. So I was trying to put into context where the genesis of these parts that have led us to today began. And it was a community that was really important as well, Chad. And was how even things don't work for me, what might be found through this research and my participation might work for somebody else and improve life for somebody further down the line. And particularly those areas that I worked in those early days, we got needle exchanges started here just on one research that happened in Edinburgh with needle exchange. And the success that we've had in keeping rates of transmission across people who inject drugs over the lifetime of the response in Australia has been a great example of how one piece of research and enabling environment can really start the ball rolling. And if we jump ahead and we look to just recent times, Chad, I think in the last 5 to 7 years, we have seen everything tipped on its head. We have seen those years of engagement and partnership come to benefit everybody in that areas of prevention, PrEP, coming from studies, and we'll probably talk about the partnership study and U equals U, and the study that people who in seroconverted relationships, one positive, one negative, came together in that study to try and finally put to bed any concerns around UVL. And so there's been just amazing advances that we see today and that we take it for granted today. And I'll be interested in discussing a bit later on some of the barriers to that ongoing inclusion, because the dynamic has changed and the things that we're required to do to be involved in that research has changed also, and whether there's still that same energy and that same sense of responsibility as a positive person to participate in that research.
A good response and a good question there at the end too, Richard, for all of us and for the panel around the role going forward. And your involvement in this for such a long time, over so many decades, you've seen that the sort of transition in how this works to where we are today. So look forward to getting more insights from you this evening. And if anyone has any questions, of course, put them in the chat. My next question is for Heather Mugwagwa. Heather is the Peer Engagement Coordinator for Positive Women Victoria. Her role involves engaging women living with HIV with research and promoting participation. She also facilitates tailored peer support for women living with HIV and coordinates volunteer peer support programs, outreach group support and workshops, especially for women in marginalised communities and from diverse backgrounds. Heather holds undergraduate and postgraduate degrees from Melbourne and Monash University. Do we have Heather with us, or has Heather disappeared? Hopefully Heather will come back and join us in a minute. So I'll hold my question for Heather. Heather, you're back. I think we have some technology issues caused by this polar Antarctic vortex shining over Victoria. Heather, I got a question for you. I've just introduced you to everyone. How are you?
Good, thanks. Sorry, I had a bit of a communication breakdown there. So
no problem.
Yeah.
You're back now. My question.
Have you introduced me already?
I did.
Okay. All right. It's
I gave your stellar credentials to the crowd. Now I'm going to ask you a question.
Okay.
So women are sometimes overlooked in HIV research in settings where the epidemic is dominated by men who have sex with men. What obligations do we have to ensure that women are part of HIV research?
I guess from my experience, because I work with women living with HIV, and from my less than 10 years of experience of working in the sector, I think the challenge will be to increase information dissemination, to have equal knowledge, between, men and women, because from my experience, I've noticed sometimes there's a gap in the knowledge, and usually when getting women to participate in research, I think there's the challenge even in terms of them understanding what's happening, what is the research about. I think there's more to be done to make sure that there's information and women are engaged from the onset of the research. I'm breaking up.
All righty, we lost Heather for the moment. So what I will do is start to introduce our next panelist while we wait for Heather to come back, and then we can hear from Heather when she returns. Professor Jenny Hoy is an infectious disease physician and director of HIV medicine at the Alfred Health and Monash University. She led the HIV clinical research effort at Fairfield Hospital in the evaluation of new antiretrovirals and new approaches to opportunistic infection prevention and management. Since moving to the Alfred in 1996, she has continued involvement in both HIV patient care and research, particularly prevention and management of the comorbidities associated with aging in HIV. Welcome, Professor Hoy. You've been involved in HIV research for decades. How has community participation changed over that time?
Thanks, Chad. So I think in the very early days, there was an urgency to actually manage opportunistic infections, manage the things that the infections and the conditions that were shortening the lives of people with HIV. And in those days, there was virtually no community participation in those studies. And then we sort of learned from our patients. Our patients would come in and say, we need to do this, we need to do that, we need to prevent this, we need better drugs, we need less toxicity. And the urgency then became finding antiretrovirals that would prolong life. And in those days, in the early 90s, the National Centre of HIV Epidemiology and Clinical Research was born. And David Cooper was instrumental in setting up working groups in that centre. And in each working group, there were at least 2, if not more, community members that participated in the discussions of what was important, where we should be going, what the design of the study should be. And for the next 15 years, community was an integral part of all of our strategy studies. Since about 2011, when the National Centre became the Kirby Institute, those working groups dissipated. And we only did a couple of strategy studies. They were important, they were enormous. They were global studies, the SMART study and the START study. But the community involvement in those studies came from the US and Europe. And there was one solitary member from Australia, despite the fact that we led sub-studies, etc. So the community, the way that I saw it, the community participation really decreased. Now, in more recent times, we still have patients guiding what is important to them and what we should be looking at. But I have to say that, and I'm disappointed in this, that for those of us that are looking at the pathogenesis and the treatment and the prevention of the comorbidities have not been engaging with community in the design of those studies or the conduct of those studies. Unlike HIV Cure, they have community participation, as does HIV prevention, as does the social research. So it's really the antiretroviral studies that are basically run by pharma now. The strategy studies don't occur, and the comorbidity studies. And I would like to see that change.
Thanks, Jenny. And I think that's part of what we're here for tonight and through this series of these discussions, and is to find that way forward so that we have that better collaboration in all HIV research and that meaningful involvement of community members, as you say. There are examples where it works well, there are examples where it doesn't work so well or it hasn't happened at all, and there are many reasons, myriad reasons for why that can be challenging, but working together, I think we'll get there and make sure that we have that engagement with the community here in Australia, as you said from your early experience where they were from overseas, but there are enough people in the Australian HIV community here who are, I believe, are interested and informed enough to really add value to the kind of research that you're doing. All righty. We seem to have lost Heather again, but we have Associate Professor Garrett Prestige with us this evening. Howdy, Garrett. To introduce Garrett, he has been involved in gay community research and advocacy since the 1970s. He has investigated HIV behavioural risk through multiple studies of gay men's sexual health since the 1980s. He has a strong relationship with gay community-based organisations, and his work informs policy and programmatic responses. So it's great to have you with us this evening. My question for you, Professor Prestige, is, as a gay man with a career in research spanning decades, in your experience, how can research go wrong? And how can poorly designed research impact on people living with HIV and marginalised populations affected by HIV?
Well, thanks, Chad. I was actually going to talk about some of the similar things to what both Jenny and Richard have said. And just because of some of the issues with the technology, I just thought I'll reiterate some of the points that Richard was making, because I think it's really important to remember historically what was happening in the late 80s and early 90s when treatments were in the process of being developed. Because those studies, as Jenny said, initially were being run in very much the standard way that clinical trials are run, and they were restricted by study protocols and all that sort of thing. And so at the same time, at that point, people with HIV were really organising themselves, and that's where ACT UP came from, into really challenging researchers to think about this in other ways, and make access much easier. So I do think that that's a really important point. And hopefully we can come back to some of this later on, because there's a history here in Australia that's actually really interesting in terms of the relationship between research and community. The other things that I wanted to touch on in response to that question, though, is the examples of research doing actual harm in relation to affected populations, especially. So, like, if we think before HIV, there was a whole lot of psychologistic research that ended up describing homosexuals as psychologically disturbed, female sex workers as emotionally traumatized, victims of childhood sexual abuse, injecting drug users as lacking any capacity for self-control. And in pretty much every case, what you see is there are examples of research confusing cause and effect, and of the old adage that correlation does not equal causation. And the consequences of that early research was that the groups that were most at risk of HIV were seen through the lens of being victims. So research was much like the way the policy and service delivery occurred, was something that was done to them, even if the practitioners believed that it was well motivated, not as something that was done with people at risk in partnership. So we've had research in the past that's assumed that, for example, having a very active sex life or the use of drugs is evidence of psychological problems. Poorly conceived research projects have argued that gay men who use sex venues, or more recently, even that men who use hookup apps are at elevated risk of HIV and STIs. So that's with the sort of not very hidden idea that it's evidence of being psychologically damaged. But even a really simple critique of that would tell you that it's not really, it's basically the very unsurprising fact that those who have an active sex life are more likely to get an infection that's transmitted during sex. Duh. But that same simplistic approach was used to justify things like closing down gay venues in the US. So it has real dangerous implications, and it almost had that effect here too. And similar things happened among sex workers and drug users, and we've seen them happening in Indigenous communities, and we've really seen some pretty outrageous consequences of that over the years. So what's the common factor here that makes these various pieces of research inadequate and actually harmful? There's methodological flaws, of course, but to me, the main failure is that they lack insight. They weren't guided by the experience of the people that they were researching and the well-being of their research subjects. So scientific endeavour is great, obviously, but without it being grounded in protecting and extending the interests of the research subjects and the good of the community, then it can also be what I would describe as a cold deliverer of well-intentioned evil. And who are the people that are best placed to protect the interests of those being researched and to make the research deliver good? They're the very same research subjects and their communities. And that's why community participation is so important. Thanks.
Thanks, Garrett. What I like about the panel tonight is that there's so many years of experience amongst the group that we can reflect back to lessons learned over a long period of time of trying to do this right, and sometimes getting it wrong, and sometimes even causing some harm from it, so that we can learn those lessons and hopefully not do that in the future. So while the panel and the discussion is about how do we do this better, let's learn those lessons from the past about how we do things differently. And I guess that's what research is, isn't it? It's looking at the data from the past or that you've collected and making sure that you use that to steer things in the right path in the way forward. All right. Don't forget, everybody, there are a few questions popping up in the chat, but we can also use the Q&A function down the bottom. And for the panelists, if you're not speaking but you see a question there, you have the option to either type your answer in there and respond to that while somebody else is talking, or you can save that and talk to it when we get to more of an open mic a little bit later this evening. I'd like to ask a question of our next panelist, who is Professor Sharon Lewin. Sharon is the inaugural director of the Peter Doherty Institute for Infection and Immunity, a joint venture between the University of Melbourne and Royal Melbourne Hospital. She's an infectious diseases physician and basic scientist. Her research focuses on understanding why HIV persists on treatment and developing clinical trials aimed at ultimately finding a cure for HIV infection. And I'm not sure whether we needed that because everyone probably knows you, Sharon. Welcome. It's great to see your smiling face here this evening.
Hi, Chad. Yeah, good to be here. God, it sounds horrible outside. I'm on a landline, so I think I'm hardwired in.
There you go. Nice and safe.
So while everyone's flopping on and off, I'm here to stay.
Perfect. Well, I have a couple of questions for you, but we'll start with this one. This one is actually about a little bit of a tangent, perhaps away from HIV, but on COVID, which is another pandemic, obviously, that we're all well aware of and facing at the moment, particularly for those of you who are in Melbourne and under lockdown. We've had some positive news tonight that we're sort of easing those restrictions in the next couple of days. But reflecting on our historic response to HIV in this country, how important is it that community participation is getting us to where we are currently with COVID? I mean, how much do we need participation of community in COVID-related policy and research as well?
Thanks, Chad. I'm very disappointed you asked me a question about my second favourite virus. Like, no, everyone, I'm sick of talking about COVID. I want to talk about HIV, and it's been actually, I'm not sure whether you know, but the UN high-level meeting on HIV has been running this week, so I've been joining it at midnight to my detriment. But it's just wonderful to reflect on, just to sort of hear the global commitment to HIV is still there, right in the middle of a pandemic, and how much we've learned, but how much more there is to go, etc. But anyway, you want to talk about COVID? I'm happy to talk about COVID. Community participation, we've, as you've heard from all of our speakers before, was just transformed by HIV. And I think Richard said at the beginning, it works. It was just an incredible model for accelerating access to the best treatment, moving the science forward, making sure that no one misses out, all of the and the urgency that people had to fight for with HIV. And in many ways, COVID is the opposite, because everyone's obsessed with COVID. So there's no fight to get noticed and to be activated. And it's sort of, the whole thing's being tipped around. But I worry a bit about the whole thing's being tipped around, meaning like that everyone just wants to move faster and faster, which is great for the science, and of course absolutely essential because we're in the middle of a pandemic. But I do worry a bit about the fact that we just haven't got those community structures set up well, and depending on what research you're going to do, of course it's all done ethically, and there's been no shortage of participation in the vaccine studies and therapeutics and all the things we're hearing about. But on the area of of social research and understanding vaccine hesitancy or these, understanding why people do get tested or don't get tested, or the behavioural issues that we're asking people to comply with or forcing them to comply with. There's just so many issues that need a community voice here, and because of the pressure, because of the at the time, everything's been sort of squashed down. Yeah, I don't think we've got those structures right yet. And even in long COVID, which I'm sure many of you know about, just 10 to 15% of people that have long-term symptoms. I'm involved in a few long COVID studies here and nationally, and even there, we haven't yet got that community engagement, and that's because what I think has been special in HIV is that there is that really high literacy around the science, and that takes a while, even though there's high literacy around COVID, there's no doubt about that. But if you're looking at long COVID and immunology, etc., you do need a time to invest in literacy. And I don't know, the whole COVID thing's moved really fast, and I think we've got a long way to catch up on the community participation and the fact that of the sorts of communities that need to be involved, so diverse, etc. So there's the outcomes from science in COVID have been impressive. Much of it, of course, is leveraged off major investment in HIV and a formula that's used for HIV. And I think it's important everyone knows that. I think about it a lot, but I think we do need to find a different way to work in an acute environment like this, in a pandemic, where you've got to assemble the right community very quickly, and I'm not sure we've done it that well yet.
I was going to say, I for one, and I'm sure others would be happy for COVID to move on out of the way so that you can get back to focusing on HIV full time and
well, that's
getting towards that cure.
Yeah, that's a little bit how Australia's viewing it, but this is just madness what's going on at the moment, chasing one case. I mean, we have to do it, but it is just out of keeping with what's going on in the rest of the world. So we've had 82 days in Melbourne of thinking that COVID's gone away, but unfortunately not.
Yeah, true. Thanks, Sharon. Associate Professor Prestige, I'm going to come back to you. I was wanting to hear from your experience of an example or key examples that you can think of where community participation in research in particular has really led to either policy or practice implications in the real world in terms of how we deliver HIV prevention programs.
Okay. I can't turn my video on, by the way.
Sure, no problem.
Okay. So let me take you back to the early days of the epidemic again, because I think that there's, and this is what I was alluding to earlier, that, here we go. So back at the very beginning, in around 1983, 84, we were still struggling to understand HIV and how it was transmitted. And so I wanted to talk about some Sydney-based things that happened, but they do have really strong national implications. So in Sydney at that time, a bunch of the doctors, and particularly David Cooper, who Jenny referred to earlier, came together and considered what they could do. And one of the things that they really wanted to do, given the real lack of information at the time, was to set up an observational cohort study among gay men through their clinics to monitor what was happening. And at the time, David was fortunately very ably assisted by someone, a gay man who was working as his assistant at the time, Brett Tyndall. And basically what they did was they turned to the gay community organisations and discussed this possibility. And by coming together in that way, then they organised this town hall meeting. And there were hundreds of gay men came. And essentially the doctors then spoke to the town hall meeting about what they were going to do. And there was this enthusiastic, yes, we'll all participate, this will be great. And that was really the very first clinical HIV study that happened in Australia. And it eventually, that study provided the foundation for what when became the National Centre in HIV Epidemiology and is now the Kirby Institute. And because of the way that that was set up, it created this model of community researcher working together that really has underpinned the way that that research has come about and been engaged with over the time since then. Now, the second part of what I want to talk about with this is, and again, Sydney-based, is that people in gay community organisations just after this was happening, then started thinking, okay, this is looking at the clinical aspects, but we also need to understand what's going on for gay men, what's going on in their experiences, and how to contextualise this clinical stuff with the experiences of gay men. So they actually then approached prominent social researchers at Macquarie University, it happened at the time, to see if they'd be willing to help with setting up a study of that kind. And they agreed. And that study was the very first HIV social research study. And that study also became the foundation for what's now known, what became the National Centre in HIV Social Research, and has now morphed into the Centre for Social Research and Health, but also Archers. And so the same sorts of things were happening in relation to among sex workers and among injecting drug users. The same sort of activity was taking place, not quite on the same scale, but certainly happening in that same sort of way. So not only was community engagement fundamental to the very origins of HIV research in Australia, it was part of the foundational model for how we do research in Australia. And while there's been problems all along the way, of course, it's built into the fabric of our research agendas. But it's also, as Jenny has alluded to, a constant struggle to maintain it. And of course, the challenges and priorities of researchers don't always sit easily alongside those of community mobilisation. And as much as it might annoy people like me who sit in the research area, but also sit in the community area, but we need community organisations and we need activists to keep raising the voices and making sure that researchers stay focused on the best interests of the people in our communities. Yeah.
Yeah, true. Thanks very much for that. I can see quite a few questions coming through on the Q&A function, and I might divert slightly to ask one of those, and any one of the panelists could jump in and answer this one, because I'm sure we all have a perspective. But David has asked, David O'Keefe, how do we overcome the expectations that people living with HIV should give their time to research when it is not always adequately acknowledged, either financially or in the research through the names on the publications at the end of the study? Interested to hear thoughts from panelists on that. Richard, do you have thoughts?
Yes, I do. I certainly appreciate in particular publications for people who may not have qualifications but may have participated in the design and mention that research. That's an ongoing issue. It's also the flip side of that, and I'd like to redirect the question a little bit, and the positive people that we've got now, and some research and other things that might require you to, through your participation, to go off your antiretrovirals, and all of a sudden you end up with a viral load for a little while you participate in a study that might further advance understandings and learnings into where HIV reservoirs sit in the body, how long before it starts to react, and really, really important questions that are starting to impact on as we move towards cure and as we move towards the potential of a vaccine, other things like that. So it is both sides of the coin. We need community members to think. And I remember looking at a study I was viewing recently, and the youngest age of the participant in that study was 37. And I understand that we've achieved this position where we don't want to mess with our health status and being well and antiretrovirals, DL and all that kind of stuff. But there is a really important conversation that needs to continue to occur around that sense of altruism that I was talking about before. But with that participation, with that risk-taking, we need to be in with acknowledgement and remuneration within those studies as well.
Very good. Thanks, Richard. Jenny, hi, welcome back.
I think it's a very good point that David has raised. I do have to say that in recent times, there's a question coming up about what we're doing to engage community. And unfortunately, what we're doing is tapping people on the shoulder, people that we know, and it's the same people over and over again. But they do become authors on the publications that come out. Community was an author on the START studies and the SMART studies and the sub-studies. So authorship is there. Remuneration, on the other hand, is not. And I'm not sure how we go about that. And that's something we need to think about. One of the things that Richard was, and Richard and Garrett actually, was, people today take one pill once a day, it's well tolerated, there's no urgency to improve treatment, etc. They're not necessarily activists, people are not they're wanting significant change. And I think that that's missing now in our response. We've made things better as far as survival and as far as treatment, and the treatment is easy in general. But yes, the remuneration is an issue, and I take the point.
Sure. And I think for many people, the fact that they're giving their time voluntarily, or their samples from their blood, for example, that will hopefully answer some questions that improve the quality of life for other people living with HIV. For many people, that's enough. And I think that's why we've been so lucky to have all that participation over many decades, particularly in trials on new drugs and now more recently in the cure trials as well. But I'm not sure personally that remuneration financially is the way forward, but it does segue through to another question in the chat there, Jenny, when you said we seem to be tapping the same people on the shoulder all the time. And there's a question from John Hall there about fatigue for those people who are the same people coming forward to participate, and how do we get that broader engagement from more people from the community of people living with HIV? And it's a question for yourself, Jenny, or for anyone else on the panel who might have some thoughts on that.
I agree with John. There is research fatigue, that is participation in research. There isn't the excitement about being involved anymore. I should say there are some people who still really enjoy being involved in research, but there is fatigue. I'd be interested to hear from people who have been involved in participation in research design and conduct of studies, whether there is fatigue there. As I said, we're tapping on shoulders, and they haven't said no as yet, but they might soon.
Sure. Garrett, I see you've got your hand up.
Yeah, hi. Just in terms of this, there's two questions here that I wanted to address. The first is about research fatigue. And I'm not just discounting the fact that people get sick of these things, but nonetheless, it's something that I've heard many times over the past several decades. And I think that it really depends on what kind of research you're talking about and what kind of issues are being addressed. Because, for example, we've had the gay community periodic surveys running for 25 years. The level of participation is as strong, if not stronger than ever. Those sorts of things have not changed. And if it's, depending on the issue, you see sometimes you get really strong responses because people are really excited by a particular issue, and others where they're not necessarily. So I think that you've got to be careful about this, that it's not a blanket thing. And the other thing is this issue of remuneration for people participating in studies. Now, maybe I'm speaking from a social research perspective, but one of the issues here that we need to think about really seriously is the level of funding that researchers get for running studies. And often they're running on the smell of an oily rag. So the capacity to be able to actually reimburse people may be very limited, and particularly for those people who are running the social research kind of studies, but also particularly people who are more junior. So I just think, let's be too blankety about these kinds of things.
Yeah, sure. Thanks, Garrett. And then, yeah, you're right. There are some studies where an incredible amount of people from the community put their hand up and participate and give their time and energy and answer those questions every year. Sharon, you had some thoughts. The kind of research you do on cure trials might be a little bit more in depth for a participant. What do you find in terms of getting people to self-nominate themselves, I guess, to participate?
Yeah, I mean, cure research is very, very different to the sorts of research that Jenny and Garrett have been talking about, that we're, especially research in the early days of true benefit to the participant. This is a very different situation where participants are often come into the study with a high sense of altruism, which is true of many areas of research, very unlike low-level low chance of personal benefit, but great chance of contribution to advance the field, and also some risk. So, it's a very different balance, but we have had enormous interest still in cure research. People really want it. It is a very hard area to move forward. We can only move forward as a partnership here, and the commitment to it's really high, and so we just have to find better and better ways to engage people. What I was going to actually comment on was, one good thing about COVID is, and there are many good things about COVID, and there will be good things about COVID for HIV, I'm sure of it, in both the science and even the way we do research, because COVID's pushed us to innovate at different ways of doing research, and that's maybe one way we address the fatigue. So we see our patients infrequently now, especially in a hospital-based setting, once every 6 months. And coming into the hospital is a bit of a drag for most people, and everyone's experienced life with, remote consultation, telehealth, etc. It's not perfect, but it has got some benefits. But, we could do research much more. It might make, take research to a person's home, take it to the, make it really convenient for people. Again, for cure research, people are well, healthy, full-time jobs, we're asking them to make a huge commitment of time. Can we just innovate more? And there's a fantastic study that James McMahon has been leading, and Jill, who I can see in the audience, have been leading from the Alfred, which is a an oral intervention for COVID. And because of the nature of COVID, they've done the entire thing remotely, meaning consent people and enroll them, etc. So I think we have to learn from that and do a lot more in a far more flexible format than we expect patients to come into hospital, sit around, try and make it as smooth as it can be, but we can innovate a lot more, I think.
I'm seeing in the chat, both in the chat and some of the questions, that the researchers who are here are genuinely interested in having that engagement with community and making sure that community is part of their research, I guess, from the beginning, from the inception through to the end. But they're still asking those questions about, how do I make that connection? How do I reach the community? How do I make sure that I've got people who are wanting to be there for the journey, as a co-investigator, a co-author, etc. But the question there from Gillian's a great question. I could almost jump to the bottom there in that discussion and see, there was a comment about co-design as well, and perhaps the importance of engaging the community right at the very beginning and in the genesis of the idea of the research piece, rather than trying to bring them in. And that's from David. But happy for any of the panelists to just jump in and comment on any strategies you think have worked from your experience in getting that engagement with community, or any barriers that you have experienced in terms of getting that community engagement that you think are still persistent and still there, that we need to talk about and we need to address to move beyond, to be able to create these linkages. Jenny.
Chad, I miss the community engagement in the working groups from the National Centre. I miss their the community's perspective. I miss what's important to them may not be important. What we think is important may not be important to the community. And I'd like to see a mechanism be recreated where we could continue to have that engagement. I think some of the barriers are that there's less, there's Sharon's doing her cure research, and then there's some HIV prevention studies, but there's less, there are less studies being done that would require regular meetings for the community. What we need is a mechanism whereby we can engage quickly, I guess. Often, there's a funding announcement, an MRFF, it comes out, you've got 5 weeks to put it all together, and that's often not enough time to get everybody around the table and to discuss how we might go about answering the question. Is the question important, etc., etc. So yeah, I would really like to see a community advisory board for that's what they're called overseas, that didn't have to meet regularly, but could meet in an ad hoc fashion with researchers. We need to get the researchers aware of where they can go to co-design studies as well, and that's missing because we don't know where to go.
And as you say, when the call comes out for the grant or the NHS application to be in, the researcher is then in front of their computer for 12 hours a day, trying to get that demanding task completed and balancing that with family and whatever else. Where in that space is that time for the genuine consultation? And I think you're right. Those co-design processes and consultations need to be happening all the time, so that when the call with financing is made available, they've already happened. And
Yes.
collaborations are already there and people are ready to go. Just need to then put in for the funding.
Yeah.
Richard, I saw you pop on the screen. Did you have some thoughts on this as well?
Yes, I did. I'm having some issues here. I'll just talk about the need for diversity within research and stuff as some of the things that might need to change to encourage that diversity. We're seeing more and more newly diagnosed people who are born overseas. More than 50% of our new HIV positive diagnoses come from that group. We're always talking about the fact that it kind of centred around gay white men, a lot of the research earlier. But we have to find ways to enable that to occur. And when we're talking about things like remuneration, that doesn't have to be a lot of money, and it can be other things as well. When you look at women engaging in research and things like that, it's simple things like if they're at home and they're a carer for their children, having that engagement at a time that's appropriate, that enables that integration and interaction. It might be something like having some meals prepared for them to take home that evening to feed their family for the time that they've provided to participate in that research. And it's also about, it takes a while to build up, Chad, and that's trust. That's trust about what's being done with my data. How am I going to be identified? Just because somebody's telling me everyone's de-identified within this research, can I trust that? We've got people coming from different cultural, religious backgrounds where there might be high levels of stigma and taboo around things like disclosure and stigma and other things like that. So we really have to, and again, it reinforces what everybody said tonight about the central role of positive people to find enablers to ensure that diversity of participation can occur.
Yeah, you raised some incredibly important points there, Richard. That the HIV positive community is not some homogenous group of, cisgendered white gay men that perhaps we think of, because that's often the face that we see or the voice that we hear, but it doesn't reflect the reality these days of who is being diagnosed with HIV in our communities, and raises a whole lot of questions there around how do we make sure when we get that consultation going that we have that diversity represented so that it's true consultation across the communities of people living with HIV rather than just one subset. And it's a shame Heather's dropped off, because it would have been great to hear her perspectives on that from a positive women and cold community perspective. Professor Hoy.
I think it was David O'Keefe, was it, that raised the question about reimbursement. I'm not sure he was talking about reimbursement as a research participant. I think he was asking about reimbursement for his time as a community member progressing a research proposal. And it'd be good to clarify the difference. But I think Garrett is also correct that most research is run on an oily rag. But it would be good to understand whether it was the participant or as the community member.
David has validated your question there. I'm also seeing in the chat from people here who are with us tonight who have some insights about where that sort of consultation might be possible between researchers looking to consult with community and community. And one is that the Institute of Many Facebook group, where I know there are a lot of people living with HIV that are members of that. Although I don't know the answer to the question myself there, whether that would be a platform that would be welcoming of people who weren't living with HIV to come in and just join those discussions, or whether that's just an avenue to connect amongst a community of people living with HIV themselves, something to explore. Liz Crock, and hi Liz, has commented that Thorne Harbour Health themselves have a community research promotion committee that look at proposals, research proposals, and provide feedback if that proposal is on HIV research. I know Sharon and her group at the Doherty have a community advisory, board and a platform there with people living with HIV who provide input and advice throughout the process of all the HIV cure research that you're looking at and doing at the Doherty. Is that right, Sharon?
Yeah, I mean, that's right. I mean, with cure research is absolutely essential because it just requires the literacy and which takes time. Not all clinicians are that literate either, so that often participants in research rely on conversations with their clinicians, and that is not necessarily widespread knowledge. So our community advisory board has just been invaluable. But I should say, we had the benefit of a grant from the Victorian government, which was which allowed us to set up the Melbourne HIV Cure Consortium. And a big focus of that was on community literacy, community engagement, community participation. Community is at the table on identifying what to fund, and then on the to some extent the design, and then participation in the protocol steering committee. So we were getting back to that thing about funding, we were in it was a great position to be in to mean that we could fund and design it properly. Then of course there's been researchers such as Jill, who's on Lau, who's in the audience, who've really focused on a lot of her work was directly with directly engaging the community in the design of how she went about understanding people's perceptions on treatment interruptions, etc. And we're actually doing a very interesting study at the moment with Thorne Harbour as one, and NAPA and others, on using HIV sequencing. We're reading a lot about COVID genomics and what it's done, how it's been used to assist in tracking transmission. A lot more complex issues if we were able to use that technology in HIV, but it is technology that will help see the end of HIV because it will allow another intervention to stop transmission, but very, very complex and many issues related, very different to COVID. And so this partnership grant is actually a partnership with the community. So we've got communities co-investigators, and again, that's funded so we can do some whole range of workshops with community, etc. So the funding does play a role. That doesn't mean that it's an excuse not to do it, but it has assisted us, I think, in Melbourne.
Yeah, totally. I'm seeing in the chat that from both sides of the coin, almost, that the researchers want that platform, that engagement. They want to know where to go to get that input from community. The community want to participate and be involved in the research. And I guess the question that's kind of there floating around in everyone's comments in the background from my interpretation is, it's just not quite clear to everyone where is that platform and where does it sit. And it doesn't necessarily have to sit in one place, but I think these discussions here are for us to try and find that solution. It could be that community needs to come together in the form of the organised organisations like Thorne Harbour Health, who's hosting the platform, and Living Positive Victoria and Positive Women, and TIM even, which is perhaps less of an associated, corporation or an entity, but it is in itself a network of people. So I think this is part of this first session tonight is part of that discussion in trying to find that pathway forward. And I'd like to thank Thorne Harbour Health for bringing us all together to explore that. We've got a little bit of time left. I see Claire Sidlow has asked a question: how people as researchers can make sure the language they used in their write-ups and the wording of the actual questions in their studies is a non-stigmatizing language. Someone like to have a go at answering that? Richard, perhaps. You're on mute, Richard. You're still with us.
I think there's some really important questions, and it's still ongoing. And some of the issues that I get most frustrated about, and I have to realise that people can't always see things through the lens that I have as a HIV positive person. And sometimes you get really frustrated that people don't immediately see the things that stand out to you. And they are specifically the things that get me most riled are about language. And recently I was at a survey and they were asking me, and they were thinking of developing an app where they might be able to provide some information around HIV hotspots of transmission in the community. And I just thought that the language was loaded, and I re-engaged very generously and spoke about my challenges with that stigmatizing language. And they came back and suggested that maybe we can talk about, instead of using hotspots, we can use the term outbreaks. And so we kind of had to progress quite slowly through a conversation about what that language means and why are you developing an app that shares this information, and then digging deep down. And this is what happens when you don't involve community in research from the beginning. When we were digging down further, that information was going to be taken from Epidata, which has a slight delay from the time the community gets to access it, and also be based on the location of the person's home address when they're diagnosed, which is not where the transmission probably occurred. It may not have occurred in their home in the Northwest Corridor. It might have occurred in a sauna in the city. It might have occurred from a hookup on an app. So it really wasn't any value moving forward, and it was really quite stigmatising. And I'm still having an ongoing dialogue around that, but it's a thing like language that's really important. That's why positive exists. So it's one ways to build those partnerships and engage with language that's far less stigmatising for HIV positive people.
Sure, thanks, Richard. Sharon, I'm going to jump back to you for a moment. I'm just pondering, my commentary before was probably very Victoria focused. And correct me if I'm wrong, are you based in Victoria or elsewhere in Australia?
I'm in Sydney.
Sydney, yeah. And so I just wanted to sort of throw to you, but then also to the broader panel in terms of finding a solution for this. We don't have to be parochial about Victoria. I mean, do you have systems that work well in New South Wales, or could what we look at setting up here as a platform for engagement between research and community be more of a national level thing that wasn't bound by the states?
So you're talking about those sorts of the sort of thing that Jenny was alluding to in terms of...
Yeah, kind of in Victoria, there's this feeling of, from researchers, where do I go to consult community?
Yeah. But I don't think that's a Victorian issue. I think that's a general issue, and one that's sort of ongoing. I mean, part of the issue for us in social research is that as the world has moved online over the past 20 years, it's changed the very nature of the way that you interact with people, and it's really required a complete rethinking. I mean, the issue that Jenny raised about the lack of those sort of community advisory committee type things, in a sense, the fact that people are now online should actually allow those sorts of things to develop more easily. And one of the things that I've been really conscious of over the past year, as we've moved even more online because of COVID, has been that suddenly we're realising, hey, we can actually do away with geography as a limitation for participation in research and consultation and stuff. So I guess the answer to your question is no, it's not a Victorian thing, it's a general thing. I don't think that I've got answers to the problem, but I do think that we do need to be cognizant of the fact that we have this tool at our disposal these days that really should allow us to do that much better. And there was you were talking about, or somebody was mentioning Tim just before, and it's actually a really good model in lots of ways for engaging with people in a way that is resonant for them. And somehow or other, I think we've got to be able to do that. We've got to think, how do we do this in a way that's resonant with people, so that they
Sure.
actually, and also that it's not hard work for them.
Yeah. And you're right, things have changed very much in the last year. I mean, when we think about a consultation or a meeting now, we shouldn't necessarily be bound to the old way of thinking about people have to get to a particular premises at a particular point in time to be able to contribute to the meeting and the consultation. And the online world creates so much more opportunity for us to be able to do this. Why can't we still get it to work? Yeah. And it doesn't have to be geography based, you're correct. And I see from the participant list here this evening, people from APWA, John Rule and others, and another number of others who are participating in the questions who I know are also based in Sydney. So it's good to have people from around the country joining us. Sharon, you had some thoughts. I see there is a question in the chat about a very specific piece of research on cure, but I'm not sure whether.
Oh, okay. I was going to say my experience has been quite different. I have found the peak orgs incredibly helpful. Thorne Harbour, NAPWA, FAO, whenever we've had some, and primarily I've done cure research, but I was just talking about that molecular epi project recently. I find going to the peak orgs has universally been always positive and helpful to find partners, community partners. So that would be my first point of call, whether we should have a standing, I actually think I like the idea of a standing advisory group, and one of the benefits of the community that was built around the National Centre was the capacity, that you really develop a lot of very good skills from seeing a lot of research projects. And so we need to invest in that, because you can't just sort of say, oh, your community, come and work on my research project. You do need a set of capacity building and skills. So that's where the investment should go. But to access that advice, my experience has generally been really great with the peoples.
Sure, and there are benefits to those organisations in the sense that they have some resources, they have broad reach into community, and they've built up trust with community over a long period of time as well. So if you as the research group are seeking validity in terms of voice of community, you're going to the right place when you're going to those organisations, but you're also going to an organisation that should be able to reach out to the depths of community across cold communities and gender and other aspects to find people from that diversity that you're requiring to be participants with what you need. Did any of our panelists have any final thoughts they wanted to share this evening as we come to wrapping up? Remembering that this is the first in a series of discussions on HIV research and the community, and the next one is going to be on June the 30th at the same time. So, I kind of feel myself that this is the first part of one of these discussions, and that we continue talking this through as we go on, and we should find some good pathways forward.
Yeah, I'll just say, thank you very much for organising it. There are still so many unanswered and important research questions to ask, whether it's in social research, prevention, comorbidities, ageing, cure, the diagnostics. We can always do things better, which is what I see what research does. It's a long-acting, injectable, all the different innovations that we're seeing, and there's been such a rich history of engagement and fabulous research coming from here because of partnerships. So thanks for activating the conversation, and I think we need to think about ways to make it really easy for people to participate in studies, really easy for people to join advisory groups and provide that capacity building and training. So anything that we can do from the research side to build that sort of capability in the community, I would love to be involved in it.
Sure, definitely. Jenny.
I just echo Sharon's sentiments, and am grateful that that Thorne Harbour Health and Living Positive actually put this together after the conversations we had late last year about how we actually can do this. So I think this is the first step, and I absolutely agree. Capacity building is critical, but it's also, I mean, we need to actually, you know, ensure that the researchers also, all of them, I mean, the ones that are here tonight all do engage with community, but there are researchers that don't, and we need to, you know, engage them in the process as well.
I just wanted to finish off by thanking all of the panelists and also thanking Thorne Harbour Health and Living Positive and the organisations for pulling this first panel discussion together. The next one's going to focus on social research in particular and engaging community in social research around HIV. So I would like to remind everyone that's on the 30th of June. So put that in the diaries and please come along and join. I'm sorry we didn't get to answer all of the questions that came up in the Q&A or the chat tonight, but I really do encourage everyone who's come along tonight, and thank you to all the attendees to join us in a couple of weeks' time on the 30th as well. And hopefully we'll be able to get to your questions then. So thank you, everybody. Have a great evening. Stay warm and stay dry wherever you are in Australia. And maybe we all see each other in a few weeks online and hopefully face-to-face at some time in the future. Thank you.
Thanks, Chad. Bye.